Yesterday in my OPD, I saw one case of 50-year-old male who had complained of dizziness in the form of lightheadedness. He actually had this symptom for 1 week duration, and for that symptom he was prescribed beta-histine synergine because he had dizziness, and so he has been taking that medication. And yesterday he presented to my OPD with the same complaint, and he reported that his symptoms are not improving. I checked his prior investigations report, and you can see this ECG was done 1 week ago. What can you infer from this ECG? Given his complaint of lightheadedness, can you see QT interval? Actually, the computer reported QTC was 530 millisecond. So I actually do not rely on computer, especially when things are abnormal. Like in this, even though he was symptomatic and QTC was showing 530 millisecond, but sometimes computer cannot recognize T wave correctly. So I manually calculated it, and I calculated like QT was 560 millisecond, and after correcting it to ventricular rate it came to 530 millisecond. So it was correct. So definitely his QT interval is prolonged even after adjusting for his bradycardia. If you want to know how to calculate QT interval in case of some confusion, like when you see U wave, when you see biphasic T wave, then you can get confused where to take the end of T wave. So I will make separate video for that, but that is different topic. Here I would like to talk in detail about long QT syndrome. So let's come back to our topic proper. So in this case, definitely his QT interval is prolonged. So I thought he is 50-year-old male. Definitely there might be some electrolyte abnormalities like potassium, calcium, magnesium, thyroid disorder, or some drugs that he may be taking that might have caused this. So this might be temporary phenomenon because he is having symptoms for 1 week duration. But prior to his symptom onset, he did not have any prior comorbidities. He was not taking any medications. Actually, this beta-histine synergine he has been taking for lightheadedness, and after this ECG was done. And I ordered that electrolytes thyroid function test. It was normal. So given this condition, do you think that he might have congenital long QT syndrome? There are variety of types of congenital variants. Some can present in adulthood as well, right? It is not that only child can manifest and there is associated sensory neuron hearing loss due to defect in potassium channel in endolymphatics. There are a variety of types of long QT syndrome, especially congenital variant. Again, that I want to go in depth in that. But definitely this can be one possibility given he did not have any prior ECG, even though he is 50-year-old. that is rare possibility, but can be. Most likely possibility is acquired long QT, but we are not able to find what is the underlying trigger that is causing his long QT. So I sent him for repeat ECG. When he went to repeat ECG, in the ECG room he had syncope. So in long QT syndrome, why patient develops symptoms of decreased cardiac output? Do you know? Decreased cardiac output means decreased brain perfusion. If there is long QT, means ventricular repolarization is occurring late. T wave is ventricular repolarization, right? So ventricle has depolarized, and after depolarization ventricle contracts, and after that it has to relax, and for that relaxation T wave should occur, right? But T wave is delayed, so repolarization is delayed, right? So when repolarization is delayed, in that time period there are some calcium channels that is open, right? And from that calcium channels, calcium enters into myocytes, and there is chance of abnormal rhythms in the ventricle, that is ventricular arrhythmia, right? Can have ventricular fibrillation transiently, or can be ventricular tachycardia, monomorphic ventricular tachycardia, polymorphic ventricular tachycardia, that we call Torsades de Pointes. But Torsades de Pointes is not that common in long QT, but can be one possibility. The thing is that there is after depolarization, before proper repolarization, and that leads to some ventricular ectopics, ventricular arrhythmia. And you know, during that period ventricle is not contracting properly, not getting enough cardiac output, and that leads to symptoms of decreased cardiac output. And when there is decreased cardiac output, first symptom can be symptoms of low cerebral perfusion. So this is the mechanism underlying his symptoms in long QT syndrome. So if we don't find any underlying trigger for long QT syndrome, we do Holter monitoring to look how frequently these ventricular ectopics, torsades are occurring, because he might require ICD, implantable cardioverter defibrillator. You know, this ICD intermittently shocks when there occurs these types of arrhythmia, and patient can get relieved of those symptoms.